Well, there's two things I want to say before I begin. One of them is I just love whoever came up with the name of the conference all together now is like brilliant. I just love that essence that name brings to all of us in the room. I also want to say that for those of people that know me in the room, and I know quite a few people and people I haven't seen for a while, and I'm just so excited, and I don't know where, I haven't found a few people yet. When you have to put slides in, like in advance, I did do that, but then last night I was having a conversation with Barb McLean and I got a different idea. And so I woke up at 5 this morning and completely rewrote my address. And so that's why I have this up here, because it's like, and I know it's a forgiving audience, and like if I don't do you right, then you're going to forgive me and everything. But I'm talking about like I'm doing something really different, and it might make some people feel uncomfortable. And if you feel uncomfortable by what I say, it's a good thing. There's nothing wrong with feeling uncomfortable, because when you work in the space of working with people who face inequities because of lots of structural and systemic reasons, you get used to very quickly feeling uncomfortable, and that's a healthy thing. Some of you also will completely disagree with me, and I know my friend Ella Roberts and Pat Porterfield and Doris too, and others will probably disagree with me on things, and that's just fantastic. And that's what open dialogue is about. Like, we don't learn and grow unless we dialogue with each other and learn from each other. So I'm going to begin. In 1984, John McKnight published the classic paper, John Deere and the Bereavement Counselor. In the paper, McKnight tells the story of the displacement of the Sauk peoples, a group of indigenous people who live in the region of what is now known as Green Bay, Wisconsin. The Sauk peoples were cast out, displaced by European settlers who arrived with a steel plow that was invented by John Deere, a blacksmith from Illinois. John Deere's new invention allowed for the kind of new agriculture that made the soil rich and allowed European farmers to grow and prosper. Within 30 years, however, the land was completely depleted and thousands of European settlers moved on. Ignoring the wisdom of the Sauk peoples, whose fields had produced generations of nourishment for the community, the land became a desert. Even the Sauk peoples had forgotten the tools and techniques that had allowed them to thrive. New technologies and innovations, while allowing for progress and innovation, can also shape the way that societies evolved. There are lessons here too for how ideas and philosophies evolved, and such is the case, it seems, with the evolution of hospice and palliative care. Advanced mostly in response to the technologization and medicalization of death and dying, the hospice movement was designed in large part as an effort to reclaim the natural course of dying. With its focus on humane and compassionate care for people at the end of life, the persuasiveness of the hospice movement lay in its promise to bring to fruition the image of the late modern natural death described by Alias as being at home, in bed, and surrounded by families and communities that love us. In the early days of the hospice movement, hospice was unashamedly reformist, actually very, very political in its attempts to advocate for quality care for people who were dying and their family members. Inspired by English doctor, nurse, social worker, and so many other things, Cicely Saunders in the 1960s, the hospice movement was initially separatist in its approach, focusing on trying to provide better care to people who were dying, who were not well served by the mainstream system. 20 years later, palliative care services began to emerge in recognition of the need to promote better care for those who were dying in hospital. And today, palliative care services have now become part of mainstream healthcare systems, at least in the global north. Increasingly recognized as a human right, however, access to palliative care is still not a given. Palliative care as a concept seems to be unanimously supported, but that's what it remains for some people, an idea that only becomes reality for the few who are privileged enough to have access to it. Those who benefit from palliative care in our province and in our country tend to also benefit from living with higher socioeconomic status and family and community support. People who are facing the end of life who also face inequities like poverty, homelessness, racism, ableism, stigma are not so privileged. Denise Hess, a palliative care chaplain from the United States, said, "Privilege is as invisible as air unless you don't have it and want to breathe." Privilege is as invisible as air unless you don't have it and want to breathe. So today, I'm going to use examples from our research program on equity-informed palliative care to illuminate how palliative care, albeit unintentionally, may privilege some people while rendering others invisible. And I would argue that such privileging can perhaps lead to inequities in the provision of palliative care and that call into question the very root structure from which palliative care originated. The Oxford Dictionary defines privilege as a special advantage not enjoyed by everyone. From a social justice perspective, privilege is the advantages people have that they don't often think about because they've never had the experience of being on the oppressed side. Understanding privilege requires an active effort to see things from the perspective of the other. While academically the concept of privilege has been contested, feminist scholar Peggy McIntosh argues that privileged people often have difficulty acknowledging how their gender, their race, their education, their class, their physical and intellectual abilities might actually obscure our conceptions of the other. Instead of acknowledging privilege, McIntosh argues that people look for ways to justify or minimize the effects of privilege without an understanding that privilege is as institutionalized as it is embedded in our society. In our research with people who use drugs and experience homelessness, we commonly hear things like those drug addicts, if they only tried harder and said no to drugs, then, they wouldn't be in the trouble that they're in. Unnoticeable to many, privilege works a little bit like wind. When you walk into a strong wind, you struggle with each step you take. When you walk with the wind behind your back, which is probably most of us in this room, it pushes you forward. It pushes you faster than you otherwise might be with little effort, almost unnoticed. It might not be immediately evident to people that being the recipient of palliative care comprises a position of privilege. I mean, most people don't wish to be in the position of being told they're dying. But most people who gain access to palliative care in our country and in many parts of the world could be considered to hold the most privilege in palliative care service delivery models because our models have evolved around a certain kind of patient. Patients of a certain skin color, mostly white, patients with relatively predictable disease trajectories, mostly cancer, people who have supports from friends and family, and the financial resources to own a home and pay for supplementary care, like getting transportation to an appointment. Such privilege significantly increases the likelihood that a person will receive high-quality palliative care, excellent pain and symptom management, assistance with advanced care planning, support for loss, grief, and bereavement, and the ability to die in one's choice. Alternatively, our research has shown that disparities in both access and referral to palliative care are evident in many underserved groups of people who lack privilege. People experiencing inadequate housing, poverty, high rates of mental health and substance use issues, immigrants and Indigenous peoples, peoples living with disabilities, as well as people with highly stigmatizing diseases such as HIV and hepatitis C, who are also on a dying trajectory, have relatively fewer supports, often lack financial resources, and death typically, at least for some of the folks that we work with, comes in an alley, a shelter, a car, alone, and being cared for by the most amazingly compassionate workers in the community who actually have very little understanding and knowledge of palliative care. Perhaps worse, people experience structural inequities, die in hospital, cared for providers that stigmatize and judge them for a life of hardships that are not of their own making and are beyond their individual control. These structurally vulnerable populations don't typically fit the profile of the kinds of patients. Oh God, do you want to turn on sticky keys? No, I surely do not. But just hold on a minute. So structurally vulnerable populations don't fit the profile of people typically admitted to our palliative care units, and the policies and regulations that guide our institutions typically don't work for a lot of the folks that we work with. And still, what I would say is that the folks that I have the privilege of being able to work with are survivors. They have to keep going. They have skills. When you have nowhere to sleep and you got to build yourself a cardboard structure to sleep in, that takes a lot of skill. It's really tough when people have nothing to eat. They face discrimination every day, and dealing with chronic illness and isolation means that good health is rarely attainable. And when they're experiencing that, we create a situation where people feel undeserving of care. Housing and shelter staff who are well equipped to work with this population can't always recognize people who are dying because they actually have no access to people's health records. For somebody who's working in a shelter who knows a person well, they won't know that they have somebody in their shelter who has lung cancer and is struggling to breathe because they don't look any different than any other person that's in the shelter that night. The final injustice for people is to not have access to palliative care when it's needed. So holding privilege means people likely have a home address, so you can register for palliative care. We have tons of people who have no address, have no phone. Holding privilege means that you get referred to a doctor or a nurse practitioner or a healthcare team that actually might know something about palliative care. That's not the folks that I see every day in our research. And sorry if we have like some people who love Donald Trump. I'm really hoping not, but you know, I just got to say that. Donald Trump might be the ultimate example of white male privilege. I'm just going to say that out loud. Privilege comes in many forms. People that we work with rarely have access to transportation. So we do some work with the cancer agency. You know, this 3 strikes you're out policy. You don't arrive for 3 appointments and that's it. People have no money to get there. How are they supposed to get there? Of course. So, you know, we once worked with a guy, he was labeled as drug seeking because he had previously had a drug addiction and was homeless. And so he went into the emergency in worsening pain and he refused to leave. And what a not uncommon story is that people are diagnosed with advanced cancer for the first time in the emergency department. But the diagnosis of an incurable disease still doesn't unlock the gates to timely, appropriate end-of-life care. Oh, I'm like, you know. I just want you to think about this because we can't talk about equity in palliative care until we think about deeply our own privilege that we hold. And we can't think about our own role in being part of a system that continually promotes that. So it might be useful at this point to stop and revisit the root structure of hospice. Way before the inception of the modern hospice movement, dying in one's home was quite customary, where family, friends, and neighbors congregated to be together in an inevitable and integral part of life. Fabiola, a Roman matron, opened a place of refuge for the sick and the dying, and these early hospices proliferated, taking in weary travelers that were destitute, sick, and dying. These early hospices cared for people that were poor, those who didn't have family, those who didn't have a home. And in this sense, we might call people who experience structural inequities some of the first hospice patients that we ever cared for in the early days. People who live in poverty and are otherwise vulnerable are often invisible in modern day hospice today. That's the same goes for people living with different abilities. The same goes for immigrant and refugee groups. The same goes for Indigenous peoples of Canada. And it seems in some way, I wonder if those hospice ideals are currently being supplanted by something a little bit more innovative, but perhaps are creating a situation where actually people are getting left behind. And I'm talking about things like the professionalization of palliative care, the professionalization of grief and bereavement, the bureaucratization of services, an almost obsessive passion for clinical trials, big data, measurement, palliative care specialization, with sometimes a very strong focus on pain and symptom management. I know some of my friends are not going to like me for that. This was the point of McKnight's story of the Sauk people. He showed how new innovations, while vital to our development, can also serve to co-opt community efforts to be of service to their own. Sometimes when we professionalize, bureaucratize, and mainstream things get lost. We become bigger. We get more funding. We do all these things, but we lose our capacity to be nimble, to be responsive, to think about how people in our communities can actually step in to help. That's why we see a lot of palliative care services and programs struggling to keep budgets for volunteer services and spiritual care resources. Think about it. If any of you are following what's happening in the UK, a lot of the UK hospices are being defunded because of the mainstreaming of palliative care. And David Clark questions how we're going to save hospices from a collapse, with a call to refocus on the roadmap that was laid out a long time ago, both by Alan Kelleher in the Compassionate Communities movement and others. We've been using this roadmap, looking at palliative care from a public health approach, and we've begun thinking about the building of compassionate communities in our field. So we have a group called the Equity and Palliative Approaches to Care Collaborative, or EPAC. EPAC is a group of collaborators informed by research led out of my team at the University of Victoria. We work collaboratively together to conduct research and develop resources, programs, services that are aimed at serving people who face inequities in their communities. We use equity and social justice as a lens and organizing concepts. And I would ask you to think about how equity actually gives us a very powerful tool to look at who current palliative care programs are serving and who they're not. Who are we directing our finite resources to? Because we're not going to get buckets of money. Equity is about the redistribution of resources. It doesn't mean that we treat everybody the same. It means that different people have different needs, and we need to think about that. So our collaborative that includes people with lived experience, researchers, clinicians, inner city workers, chosen family members and friends, administrators, peers, volunteers, about 70 of us right now. We work together to break down silos in care of which structurally vulnerable people fall. And we believe that understanding and caring for people who face inequities and experience declining health is a collective responsibility. People who face inequities in our system, and more specifically within palliative care, are often seen as people who need to be fixed, or are so often seen in hospice, in palliative care, and in the homelessness not-for-profit industrial complex as in need of our charity. But feeling bad, feeling guilty isn't the reason to step into this kind of work. This is not about doing things to or for people who are made vulnerable by the structures that are in place. We have watched other groups coming into our equity work, wanting to build compassionate responses, but without due consideration to the complexities of the work itself. And an acknowledgement that the how you do work in these communities is much more important than what you do. So we aim to shift the gaze to focus on capacities and strengths in communities rather than deficits and needs. To people who are maybe following us a little bit in our work, our research has resulted in some pretty cool innovations in Victoria. This is one of them. And sorry for my Island Health End of Life Program colleagues for this old slide. We just haven't got out to take any new pictures. But some of you will recognize Fraser Black and Kate Leahy. They were our first palliative care physician and nurse on our inner city mobile palliative care team. They are a team that works together with other clinicians, community partners, the university, and all those collaborators I talked with in EPAC to provide a palliative approach to care for people who face inequities. They're a spoke in the wheel. They're not the wheel. They are a spoke in the wheel in an effort to build capacity within our communities to care for their home and to create opportunities for connection, to think about collective grief that is occurring in the midst of a 8-year public health emergency due to a toxic drug supply. And I can tell you the grief experienced in these communities is profound, it's complicated, and it is not an easy fix with an in-service on grief and bereavement. We don't have to be saviors of people. That's not what people want of us. But if we're to meet our core mandate in palliative care, we should focus on where we started from, and we need to remember the importance of building allies, co-conspirators in our communities. We could work with people like Paige Phillips. She's a peer navigator for drug users who is in our community collaborative, unfortunately died 2 years from a drug overdose. She came to one of our meetings. We meet every 2 weeks for 2 hours. We did that for 2 years. We now still meet monthly, and that's been going on for about almost 9 years now. People haven't left, people don't want to go. These are people that came into our community and said, I know nothing about palliative care, what does palliative care mean? And also only came in because I hired somebody who was a harm reduction worker who knew everybody and said to their friends, could you just come and talk to my boss about this? Like, this is actually true. Could you come into this group, because then I'll look good for my boss. The best hire, one of the best hires. I mean, I have amazing staff. Some of them are here. And everybody's amazing. Carolyn. But we have power to use our privilege to help others. So privilege isn't a bad thing. It's not a bad thing. We have the privilege to use what we know, our knowledge and our wisdom. And what happened to Paige is somebody in the community died. It was an absolutely horrendous situation. And she came into a meeting and was devastated. And in an ever so gentle way, I said to her, you know, we do this thing in palliative care called advanced care planning. And She went and downloaded the 50-plus page document that we like to give to people. And oh, that's Bernice. Sorry, I'm losing my sights. Oh yeah, she's right there. She came back with a 6-page advanced care planning document and said, I want to do advanced care planning in shelters and housing. And that's what we did, because the community told us that's what they needed. The social workers in the hospital love us because people are coming in with advanced care plans. We get to work with people like Bernice Camano. She's a member of the Urban Indigenous Peer Network in Victoria. She came after about 2 years of working together. She said, I just signed up for the death doula course, Kelly. I want to make palliative care come alive for urban Indigenous people who don't have access. And in the process of this, I got to meet a really wonderful young man who's still in our action team, actually is now involved in our Healthcare Excellence Canada, a collective. And I said, it was about 9 months. We hadn't actually started data collection because when you go into a room of people who have experienced such profoundly unjust deaths in their community, they come into the room in rage. I'm not talking they're crying sad. They are mad. So could I actually say anything about palliative care? No. And we sat for 9 months, collected no data, meeting every 2 hours, every 2 weeks, to actually just let people talk about what was going on in their world. And then I was scratching my head and I'm going, God, like the funding agency, like I need to do something. And Piot said to me, why don't we do a zine? I'm like, what's a zine? I don't know what a zine is. But anyway, that's for another time. I said, okay, let's do a zine making workshop and ask people, what does palliative care mean to you? And this was his definition. Palliative care is a collective responsibility, an act of love, a revolutionary practice, a process informed by compassion and empathy. It's person-centered. It's about fighting injustice. It's about removing barriers. It's about as much about life as it is about death. It's heart-centered and complex. And if you could see the small writing behind it, he was telling the story of our collective community. And there's a lot of F-bombs in that. It said, fucking injustice, fucking injustice, fucking injustice. That is how people felt. Yes, I know I'm a Canada Research Chair. I just swore on the stage. It took this, Piot Burek is his name. He's like some people know him. He is just the most amazing, amazing young man, to remind me and the other palliative care people that have been engaged with us in our work to check our privilege and remember the core mandate of what palliative care was and should continue to be, and to ensure we nurture our collective communities to come together in solidarity and support of each other. Thank you.
Oh.
God, that was hard for getting up at rewrite. I literally, you can ask the BC Centre people. These are a totally different slide deck than what I sent them. Anyway, thank you.
Wow, Kelly, thank you so much for that talk. I don't know, can we just thank Kelly? We have a few minutes, so I'm just asking if there's questions or comments. I think we've been challenged not just to sit in our, not just to listen to a talk like this, but to potentially sit in our discomfort. Because if we sit in our discomfort, sometimes great pearls of wisdom emerge, right? But we have to be willing to hear and to listen and to be challenged and to use our privilege to make a difference, is what I heard. So, any questions, comments? Just briefly before we move on. I think that we would all echo that. So, sorry, no mic runners right now, but basically it was an expression of saying thank you to Kelli for challenging us. Thank you for making visible some inequities in our system that maybe we weren't aware of, for the kind of compassion that she and her team have demonstrated, caring for people who otherwise would have no voice. And for the very productive ways I went to their session earlier today, that they're actually using the information that they've heard to actually structure new ways of meeting needs across a huge spectrum of need across Canada. I don't know if you want to say anything more about that.
Yeah, I mean, it's super cool because for somebody who's been a clinician for a long time and where I actually consider my heart to always be, what has been, you do research and you're like, oh, who's listening to that research, blah, blah, blah. So like Health Canada funded Healthcare Excellence Canada and the Canadian Partnership Against Cancer. And it's like the best knowledge translation platform I could ever have. It's like 23 teams across Canada were coaching to integrate equity into their work in its various forms. So it's not, I talked about homeless people and people who use drugs because I'm very familiar with those communities. But there are communities of people who are immigrants and refugees, people with disabilities, people who are Indigenous, as I said, and other communities that face multiple intersecting vulnerabilities. The opportunity to actually spread to 23 communities across Canada and actually learn about how do these concepts work? What kind of models are coming out? Because what works in my community is not going to work in your community. So again, it's about the how we do the work. I can give you a thing and say, here's the list of 10 top things to do around equity-oriented care that might not mean anything in your community. So I really, everybody knows me for the work that I'm doing in homelessness and working with folks who have drug use issues. But the issue is not just around, it's not about homelessness, it's not about drug use issues or mental health issues. It's about we fundamentally have people that we're not serving. And we do an amazing job of the people we are serving. But the folks that don't fit that profile I outlined, they are in trouble. And I don't see us stepping in the way that we need to. So that's my challenge out to you. It's not to say you're bad people. It's not, I know, this is my community for 30 plus years. But I entered palliative care in AIDS. And what I saw of the way that people were treated, of the way that families were pushed to the side, or community advocates, or a partner of a gay man who had been partnered for years and we wouldn't talk to anybody but the biolegal family, the stigmatization, the fear, I see the same thing playing out still. And it's time to move beyond that. It's time to close that gap and take action. So that's my challenge to you, even in your small ways. We might not be able to change every system, but we actually have a lot of power to use our own privilege to change the things that we have control over. Okay, thanks.